A few years ago, my colleague Catherine Sleeman gave a great TED talk at Royal Albert Hall where she spoke about the incredible progress that had taken place in medicine over countless decades. But despite that, mortality reigned firmly fixed at 100%. We know that is an immutable fact. We know that death doesn't discriminate, but it does when we start focusing down on minoritized communities, people who live in materially deprived areas, and intersectionality therein. Over the last 20 years, I've done a great deal of work that's focused largely on disadvantaged dying and the experience and the outcomes of care for people and their families from Black, Asian, and ethnically diverse communities in relation to location of death, in relation to the interface between symptom attributions and religion and faith, focusing on newer illnesses amongst certain ethnic communities, for example, multiple sclerosis. Taken as a whole, and then when we start to think about material deprivation, and then the litany of reports that precede my work, for example, the Black Report from 1984, the Health Divide, and the Atchison Report, which also focused on inequality and inequity when it comes to health and illness and ethnicity. They paint a really bleak and sobering picture. What happens in this room today should change lives. In palliative care, we talk a lot about location of death. Where people die is really important. We focus on where people want to die and how can we make that possible. And a good number of surveys, and I'm going to take my hat off to people like Barbara Gomez, who's done a great deal of work in this area that's looked at preferences across a variety of European centres, where predominantly, given the hypothetical scenario, people said they wanted to die at home, followed very closely by hospice, and the least preferred locations were institutional settings like hospitals or care homes. And this is a really powerful statement. A really powerful mission statement way back when Cicely was contriving and devising what St. Christopher's would represent. In hospice care, there will be no barriers to race, colour or creed. And these were really laudable aspirations. But the reality has been very different. Shame on us. So, I'm going to focus on just a few hotspots. This was a piece of work I did several years ago where I analysed close to 95,000 cancer deaths over a 10-year period in London. And I wanted to understand the relationship between ethnicity and location of death. And very regrettably, death registration certificates, you may or may not know this, don't record ethnicity. They only record country of birth or country of origin, which meant that we had to focus on first-generation migrants, and which meant that second-generation and first-generation migrants were completely invisible. So that said, what did we discover? We discovered that people from Black, Asian, and ethnically diverse communities did not die at home as often as their white peers, after taking into account all other factors. And when we think about hospice, which is the bread and butter of the work that you do, as well as servicing the care of people in the community, we discovered that when we looked at deaths in hospice compared to all other locations, using white British people as the marker, people from certain ethnic groups were palpably less likely to die in a location that provides an exclusive service to a social elite. So at the time, I hypothesized what the reasons for this might be, and I did work that focused on awareness of dying or awareness of palliative care services in relation to demographic factors, and I focused down on people's postcodes, which gave us a metric for how rich or poor they were, how much money physically they had in their pockets. And what we discovered was that people who lived in materially deprived areas, areas which were largely populated by Black, Asian and ethnically diverse communities, were on average 8 times less likely to understand what hospice was, what palliative care was, what Macmillan nurses were. And I said, that's the problem, they just don't know. But I have revisited that notion over the last period, because that places a burden of responsibility on those individuals to come forward to be aware of the brilliant care that you offer, rather than us actually saying, how can we engage with certain communities in a much more creative way and get them on board and share with them and open up our doors to tell them what we're doing and bring them in to share the currency of that superb care. The other hotspot is pain. Now this again, I'm not going to teach you how to suck eggs. We know that pain is a very prevalent symptom in advanced disease and specifically in cancer. We know that the prevalence of cancer pain goes up to in excess of 90% in the most advanced stages of the disease. We know it compromises what we might refer to as a good death. We know that poorly managed pain is a frequent reason for crisis care or out-of-hours care with GPs, or a reason to want to go to emergency departments in the middle of the night because that pain is poorly managed. And when we start thinking about how pain is managed, we know that there are some really simple solutions out there, pharmacological agents like opioids or morphine, which is a quality marker for managing pain. And when we start to understand the interface between ethnicity and pain, we have to go across the pond to really explore some very rich data, some beautifully and articulated studies that have examined this in great detail. And what we discover from those studies is that people who are African American and non-white Hispanic are more likely than not, after taking all other factors into account, to get subtherapeutic doses of morphine to manage their pain. Period. What do we know of the situation in the UK? Very, very little indeed. We know from the National Cancer Patient Survey that people from Black, Asian and ethnically diverse communities are less satisfied with the management of their pain than their white peers. But beyond that, no one has ever done any work to quantify material differences that make a difference to cancer pain at the end of life. I did a case note audit at a hospice very close to where I work. I had 40 Afro-Caribbean and 40 Black Caribbean and 40 white British patients. And what we discovered was that the equivalent daily dose of oral morphine was nearly half as much less for those individuals from those 2 ethnic minority commutes compared to their white peers. And here's a quote from a PPI person I've engaged in a study that I'm running with Sabrina in the new year. So the reasons for this are complex. They are patient-based or person-based in relation to symptom attributions, potentially poor relationships historically with healthcare professionals where they haven't felt empowered to talk about their pain, and also health professionals, particularly where the individual states that their pain is very severe and they do not share the same ethnic identity as the person who is assessing their pain, and their pain is not taken seriously. And then above and beyond that, the conscious and unconscious biases of the professionals who are caring for them. So, at last, and I'm so grateful for this, NIHR are taking this issue really seriously, and they funded a study which will take place in the new year, which will examine for the first time in the United Kingdom the relationship between ethnicity and opioid prescribing in the last 3 months of life in relation to health service use. And this is a study that I'm running with Sabrina. Let's move on to another hotspot, and I'm going to bring you right up to speed with the pandemic. And we know the pandemic put health systems under considerable stress. There was not so much as a micromillimeter of elasticity in terms of what services could do. And as a consequence of that, the great and the good came up with very important guidance on which patients to escalate to ICU and which patients to potentially de-escalate in terms of triaging and reverse triage. NICE put together the rapid guidance for critical care. And something that they emphasized at the time was that they needed to focus on the likelihood that a person will recover to an outcome that's acceptable to them, and that wherever possible, healthcare professionals should ask that individual what their values and preferences are, or to ask their family members. If we go back to the States, some very elegant algorithms were constructed that focused on which were the best candidates who might benefit from ICU treatment and escalation and ventilators. And they focused on morbidity and mortality, and they focused on the number of different conditions that individuals had and whether patients had previously had issues with their kidneys. And what they discovered was, after they went back and looked at the data, was that the lion's share of those individuals who were denied ICU care were living in areas, geographical areas, that were populated by minoritized communities. So the issue is, if they weren't getting care in ICU, what was their experience about? So we come back to the United Kingdom, and this is where I hand over to my colleague Sabrina to tell you the story in the UK.